Hello everyone, a very good evening. Today let's discuss on an important topic, approach to chronic diarrhea in children. This can be asked in your university examination as your 10-mark question or as your short notes also. So talking on with the definition of chronic diarrhea. So when you call the child to have a chronic diarrhea, that is when the duration is lasting for more than 4 weeks. The duration is for more than 4 weeks, or in infants if the duration is for more than 2 weeks is considered as chronic diarrhea. First point. Second point is it is usually non-infectious and it is associated with malabsorption. Fine. So here you will have a confusion between persistent diarrhea and this chronic diarrhea. Okay, so I'll talk about persistent diarrhea definition also. So while coming to your persistent diarrhea, is an episode of diarrhea or due to an infectious etiology that starts acutely but lasts more than 14 days. So we're coming to persistent diarrhea. So this persistent diarrhea is an episode of diarrhea or due to infectious etiology which starts acutely but it will last for more than 14 days, right? Okay, it can be also due to secondary to your lactose intolerance, antibiotic use, or a fungal superinfection or urinary tract infection or some sepsis, and it can be compounded by your primary undernutrition also. So this is the meaning or difference between your persistent diarrhea and your chronic diarrhea. Yes. Next is your etiological classification. So the etiological classification is based on the age of onset, when the child start to get the diarrhea, at what age the child is getting the diarrhea, and what are the presumed causes for this diarrhea. So based on age, if a neonate is having a chronic diarrhea, it can be due to necrotizing. These are some of the common causes. Okay, first one can be due to necrotizing enterocolitis, or it can be due to congenital intestinal abnormalities. Third, it can be a congenital chloride or sodium diarrhea because of the transport failure. Okay, congenital chloride or sodium diarrhea. Fourth, it can be due to short bowel syndrome. Well, coming on to a child with 2 weeks to 6 months, the most common causes are, first one is your infection, second one is your cow milk protein allergy, third one it can be due to tufting enteropathy, fourth it can be due to autoimmune enteropathy, right? Yes. Next, when the child is between 6 months to 2 years of age, the common causes are, one is your lactose intolerance, second can be due to your cow milk protein allergy, third it can be a functional diarrhea. So what is the meaning of functional diarrhea? I explain this functional diarrhea in this video. Okay, so functional diarrhea. Fourth, it can be due to immune deficiency, right? Yes. Next, when a child is between 2 years to 5 years, the causes are infection, secondly celiac disease, third immune deficiency, fourth it can be due to secondary lactose intolerance, fifth it can be due to your inflammatory bowel disease. Next, the common causes for a child to get diarrhea more than 5 years of age is again coming to infection, second one will be your inflammatory bowel disease, third one is your TB tuberculosis, fourth is your celiac disease. Okay, and it can also be due to related to your immune deficiency, that is common variable immune deficiency disorder also, right? Yes. Coming on to our functional diarrhea. This functional diarrhea is one of a common cause in a child to get a chronic diarrhea between 6 months to 2 years of age. So what is the meaning of a functional diarrhea? So the criteria, when do you tell a child to have a functional diarrhea? So you have a criteria for this. So criteria to tell that the child is having functional diarrhea is when there is a painless, recurrent passage of stool of more than or equal to 4 large unformed stools. So each word is important in this. Every day. Okay. So first is when the child is having painless recurrent passage of more than or equal to 4 large unformed stools every day. Second, the symptoms. This symptom is lasting for more than 4 weeks. Third point, the onset is between, when the child's age of onset of getting this type of diarrhea is between 6 to 60 months of age. Fourth, there is no failure to thrive if calorie intake is adequate. So there should not be any failure to thrive if the calorie intake is adequate. Okay, so this is the meaning of your functional diarrhea or criteria for your functional diarrhea. Next, so how do you classify a chronic diarrhea when a child comes to you in your OPD or in your OPD? So we classify this chronic diarrhea into osmotic, secretory, fatty and inflammatory diarrhea. Osmotic is mostly, it is diet related. When you stop a particular diet, the child's episodes, the episodes of the passage of stools will also decrease. This is diet related. While secretory is mainly transport related. Okay, yes. So in osmotic diarrhea, the solute draws the water into the lumen. So the solute is, for example, if the child is having a lactose intolerance, the lactose that is present in the breast milk or lactose that you are giving it in your powdered or a formula milk, that solute will draw the water into the lumen, which is causing your diarrhea. So the solute draws water into the lumen. Next, in secretory diarrhea, it is mainly because of your channel mainly your chloride and the sodium channel disturbance. So when there is a derangement of fluid and electrolyte transport across the epithelium. So when there is a derangement of fluid and electrolytes transport across your epithelium. Okay, fatty diarrhea, fat malabsorption, it can also cause your diarrhea. It is called as steatorrhea. Next, inflammatory is mainly because of your immune response. So what are the causes for your osmotic, secretory, fatty and inflammatory diarrhea? So the cause of your osmotic, I am telling only few causes of your osmotic diarrhea is like lactase deficiency. So when there is an enzyme lactase deficiency is being present, the child get the lactose intolerance, that is, the child will not be able to absorb the sugar that is being present, that is leading to your lactose intolerance. Next can be due to when a child or when the patient uses a osmotic laxative like magnesium sulfate. So when the child uses your osmotic laxatives. Okay, next, coming on to your secretory diarrhea, causes can be due to bowel resection, or it can be due to mucosal defect. Third, it can be due to a transport defect also. Well, coming to fatty diarrhea, it can be due to pancreatic insufficiency. Second, it can be due to intraluminal malabsorption, particularly to your fatty substance. Next, in immune response, it is your inflammatory bowel disease, that is your Crohn's disease and your ulcerative colitis, right? So this is the way you classify chronic diarrhea. So before classifying it as osmotic and secretory diarrhea, you need to know the difference between different main points between your osmotic and secretory diarrhea. So in osmotic diarrhea, how will be the stool? So the stool in osmotic diarrhea will be a semi-solid one. It will be loose to semi-solid one. Okay. Next, while in secretory diarrhea is usually watery. Dehydration is mainly present in secretory diarrhea. Why? Because it is a large volume stool. While the dehydration is not usually present in a child with this osmotic diarrhea. Ill looking is not present here, but it is present in secretory diarrhea. Perianal excoriation is present in osmotic diarrhea, while it is not present in your secretory diarrhea. Response to withdrawal of the food is present in osmotic diarrhea. Here it is, there is no response to the withdrawal of food. While stool pH will be less than 6 here, while it will be more than 6. Stool sodium will be more than 90 milli equivalents per liter, while here it will be less than 90 milli equivalents per liter. So why I am telling the stool pH and stool sodium? Why? Because when you give a stool sample to check for pH and the sodium and osmotic gap and all, so you have to know this difference. Okay, so osmotic diarrhea is mainly diet related, due to which the child can have a perianal excoriation. So when you stop the particular diet, the child's diarrhea will also stop. While in secretory diarrhea, it is not related to the diet. It is mainly because of mucosal problem or the transport channel defect. So because of that, the child's stool pH will be more than 6, and the child will start to excrete more of electrolytes through your stool, so that the child will go in for dehydration and child will be very ill looking. So this is the difference between your osmotic and secretory diarrhea. Well, if you find a child to have a fatty diarrhea, how will you evaluate it? So when there is a steatorrhea, the initial step involves the estimation of a fecal fat. First you have to do an estimation of a fecal fat, right? If it is high, if the fecal fat is high, next step will be you have to estimate your fecal elastase level. Okay, when this fecal elastase level is elevated, then it is mainly suggestive of intestinal fat malabsorption. Okay, next, if the fecal elastase level is low, then it is mainly because of your exocrine pancreatic insufficiency. Okay, so this is the difference between, or this is how you evaluate a child with a steatorrhea. Okay, next you have a stepwise evaluation of a child with chronic diarrhea. So stepwise evaluation of a child with chronic diarrhea. So initially you have to do CBC routine, okay, ESR, glucose, stool microscopy and stool culture, right? Next, second tier of investigation will be your stool electrolytes. Stool electrolytes to mainly differentiate between your osmotic diarrhea and your secretory diarrhea. Stool electrolyte, stool fat, okay, that is fecal fat, lipid profile. If the child is more than 5 years of age, you have to look for celiac serology also, or if there is any family history, then you have to work out for the celiac disease. Next, you have to do a primary immunodeficiency workup. For example, in a child with Wiskott-Aldrich syndrome, the child will have a bloody diarrhea will be present, or the child can also have a chronic diarrhea in that case. So you have to do a primary immunodeficiency workup and HIV workup. Third tier of investigation will be your stool alpha antitrypsin and fat soluble vitamins. Next tier will be your imaging studies, that is your endoscopy. upper GI endoscopy or your lower GI endoscopy. Then you have to look for a biopsy, that is electron microscopy. You will look for the biopsy, and your other investigation will be your small bowel follow through. So these are some of the investigation, stepwise evaluation of a child with a chronic diarrhea. So this imaging like USG abdomen will be useful imaging tool to look for your small bowel like lymphadenopathy or strictures, or in case like pancreas for your calcification, strictures and size of pancreas, that will be useful. Okay, right. Next will be your treatment goals. So what are your treatment goals? So the goals of the treatment are, one will be your first, if the child is having a secretory diarrhea, the child will go in for a dehydration, so immediate resuscitation by according to your plan A, B and C. You have to do a immediate resuscitation of the child. Next will be a management of your underlying etiology. Third one will be your nutritional rehab. Fourth will be you have to prevent the complications. Okay, so these are your treatment goals. First, so after your resuscitation workup, next in the initial phase of this nutritional rehab, you have to supplement micronutrients. So initial phase. So in the initial phase, the micronutrients should be supplemented for 2 weeks, similar to your persistent diarrhea. Next, the calorie content of the feed should vary depending upon your underlying etiology. So calorie content or the type of the food will depend on your underlying etiology. Okay. So this is how you do in your nutritional rehab. Okay. Next, diet modification. Which are the conditions that will require your diet modifications? So the conditions that require your diet modifications are, one will be your cow milk protein allergy, where you have to avoid all your dairy products. Next, in your lactose intolerance, you give low lactose diet or lactose free milk. So in lactose intolerance, you give a low lactose diet or lactose free milk. Next, in celiac disease, you give a gluten free diet. Fourth, in a cholestatic liver disease, pancreatic malabsorption condition, you give the medium chain triglyceride based diet. So in a cholestatic, like in biliary atresia, in a cholestatic liver disease, pancreatic and in malabsorption condition, you give MCT is nothing but medium chain triglyceride based diet. Then you have to maintain adequate calories in all the children. In an exclusive enteral nutrition is mainly given for your inflammatory bowel disease, supposing if the child is having. Okay, and parental nutrition can be given whenever the child is having a short bowel syndrome. So this is a short note regarding how do you approach a child with a chronic diarrhea. Thank you. And many members have asked regarding electrolyte imbalance, that is mainly your hyponatremia and hypernatremia correction, and also for approach to a child with developmental delay. Okay, so these are the two topics, and which we'll cover in our next video. Thank you so much.